So, good day to everyone. I'm delighted to welcome the participants from across the world. This webinar series is brought to you by ILAE, and my name is Dr. Kamornwan Katanyuwong, pediatric neurologist and Secretary General of the Epilepsy Society of Thailand. And this is my great honor to serve you as a co-chair for today's fifth webinar in the AOEC series. So over the next 90 minutes, we will present 3 pre-recorded lectures from the ASEPA Didactic session at the AOEC India meeting earlier this year. And each talk will run around 30 minutes. And once all the 3 are complete, we will open the floor for a live Q&A session. So without further ado, I will begin with the first lecture, Genetic Testing in the Clinic, a Practical Guide by Professor Ingrid Scheffer. Let me introduce our speaker. Professor Scheffer is a physician scientist at the University of Melbourne, Florey and Murdoch Institute in Australia. Her nearly 3 decades of pioneering epilepsy genetic research have yielded over more than 700 publications. Professor Scheffer is passionate about translating discovery into the better outcomes for patients and family. So please join me in playing Professor Scheffer's presentation.
Here are my disclosures. So what I'm going to address now, if we'll move forward, which it's not, let's try down here, is the why you would do genetic testing, the who and the how. So why does etiology matter? And I hope you'll look at this and go, I know all this, but I think it's really important to think about this for all of the patients. Firstly, it's an answer for the patient in front of you, be they a child or an adult. And in adult land, I think it's even in some ways just as important, and people have often stopped looking for an answer. And that can really end the diagnostic odyssey for families, and they can move on from from why did this happen to this is what's happened and how can I address it? Oh dear, let's try that one. No. Got a bit of let's try this. And as Helen has already addressed, it helps you to identify these comorbidities, as these are very much multi-morbidity diseases. It informs prognosis for the patient in front of you. Are they likely to grow out of their seizures or not? For example, a child with KCNQ2, a baby, might well grow out of their seizures, or they may not, but at least you can tell the parents there is hope for that, but they may still have a whole range of morbidities. It certainly guides your management from the very get-go, from the day you get that genetic result, if it is a genetic result, or indeed if it's a focal cortical dysplasia, it guides the way you move forward. It helps you to avoid unnecessary investigations because you have an answer. It informs recurrence risk. So those of us dealing with young children, families usually are planning more children, and it helps them to do this in an educated and thoughtful manner. If you're dealing with adults, then their siblings may be very worried about their risk for their own children, and you can give them very accurate data about that. And very importantly, it enables families to join the international community, and that can offer enormous support and education and help inform us. So I actually say to the families, you can now become a world expert in whatever gene, PCDH19, and then we can work together. And if you see something interesting on the websites or the family chat rooms, come back to me with them and we'll have a look at whether it's scientific and whether we should go forward. And this is becoming quite a big issue because families are jumping onto the bandwagon of drugs that are not proven. The SYNGAP1 community has just recently done that. Some of the American SYNGAP1 parents, they have a scientific board. We, the scientific board, said there's no evidence for this, and yet the families are still paying a lot of money to to get a drug which has no scientific backing. So I think we really need to be very aware of how this landscape is changing. It's wonderful to have more consumer engagement, but equally we need to make sure that, you know, what someone says on Facebook is not the same as what we say when we see families. And ultimately, of course, we'd like to prevent their condition. So how does it make a difference? I think if you get a genetic test and you find a pathogenic variant, you move a long leap forward this is doing funny things, let's try again, to a precision diagnosis. So you've moved a huge step to knowing why that child or adult has their disease. It helps you from the day you get that result to optimise anti-seizure drugs, and I'm hoping to have time to share a case with you to highlight what a difference that makes. It helps you understand their other morbidities and genetic counselling, as I've said. And in the future, we're looking forward to precision medicine. Now, everyone thinks that's gene therapies, but there's a lot more to precision medicine than gene therapies. It can be novel or repurposed drugs that are designed to target the functional problem. Ideally, we're hoping it will move us to a cure, and even more so that one day we'll be able to move to prevention. Can you see that one? No, you still can't see it. I'm just trying to get my laser pointer up. There we go. So genetic diagnosis immediately helps you to think about your anti-seizure medicine selection, and that may be a precision medicine approach. And the precision medicine may be very simple. It may be something you have in your armamentarium today. So if you look at this baby, this is a mother's seizure diary as recently as 2018. The mother made the diary of her child at 5 months starting to have convulsive seizures. The paediatric neurologist, who is not me, started this drug levetiracetam, one we all know well, probably very overused. I hope people realise that in babies these days. And you can see here it doesn't do very much. Here the paediatric neurologist started to use a different drug, oxcarbazepine, and you can see here the seizures just go wild. Why is that? What do you think's going on? It's exactly what we've been hearing about from Professor Cross. This baby had Dravet syndrome, and the child neurologist didn't think about it at onset at 5 months, used the wrong drug, didn't do anything, and then used the contraindicated drug, a sodium channel blocker. So when we've, and Helen's addressed this to some degree, but I don't think it's a problem. I think it's something that deserves reinforcement. Doesn't matter what sodium channelopathy a child has or adult. If they've got Dravet syndrome, they have a loss of sodium channel function in the SCM1A mutation, and they have seizure exacerbation with carbamazepine and oxcarbazepine. This jury is still out on lamotrigine and phenytoin. And phenytoin is very important because we do know that it can be as effective as levetiracetam in these babies and adults if they present with status epilepticus. So we have to be careful about the concept of a blanket sodium channel blocker ban, because some of them may be good in these babies. Clearly oxcarbazepine and carbamazepine are bad, and even in the adults you heard if they were removed the patient could improve in terms of cognition. But I think phenytoin is one where we still need to think about it. If you look at other sodium channelopathies, SCN8A and 2A with the early infantile gain of functions babies, you see that seizure control can be really good with carbamazepine, phenytoin and oxcarbazepine. And although these are severe disorders and they will be left, or they're usually left with profound impairment, they can still, you can control seizures, which is a major step forward. So it's just to say that the sodium channel epilepsies have a spectrum of syndromology, from the self-limited end for SCM1A of genetic epilepsy with febrile seizures plus and Dravet syndrome, both associated with loss of sodium channel function, to the gain of function early infantile DE, which is even much more severe. With SCN2A, you see a similar picture with a self-limited familial neonatal infantile epilepsy, and then the later ones, both with loss of function, DEEs, but the early infantile, of course, is gain of function, and every time I hope it'll work, it doesn't work. And then SCN8A is, of course, much more mixed, again, with a spectrum of different presentations. And just to make our lives even more complicated, we now know that some have mixed functional effects. So how are we in the clinic going to know which way to go? We're not. And we need to ask our physiologists, look at the literature, to try and determine the best treatment response. So, turning now then to the who should you be thinking about performing genetic testing in? And I'm sure you all know the framework of the ILAE for classification of seizure types. And we've expanded this a little bit to include where the DEEs fit, and that is within the combined generalised and focal most commonly, but some are more generalised DEEs, some focal and some unknown whether they're generalised and focal. And so who should you be thinking about? Well, I think that you should think about genetics in every patient you see. Is that practical? And particularly in a country which is under-resourced, it probably is not. But I still think it should go through your head and think about the testing you should consider. And why is that? Partly because these patients have a range of multi-morbidity diseases, and Helen has already shown you this slide, but just to say that in the DEEs they usually have a whole accompaniment of morbidities, most commonly intellectual disability, often behavioural problems, mood, autism, sleep problems, movement disorders such as chorea and dystonia, a decline over time in their gait, ataxia, some have cerebral palsy, gut problems, constipation, anorexia, weight loss, dysphagia, the list goes on. But we don't need to just think about the morbidities in the patients with the developmental and epileptic encephalopathies. Most of our patients of normal intellect also have issues. They may just have simple learning difficulties that affect how the child learns. They can often have mood disorders, sometimes psychosis, which is often heart-rending when that occurs in your adolescent or adult patients, sleep problems, tics, tremor, ataxia, got two tremors, constipation, anorexia, weight gain and weight loss, all issues that you need to consider when you're looking after that child or adult of normal intellect, what is going to be best for them. And also pointers to the fact that maybe there are other things going on and genetic testing is even more important. And just to say that a whole host of all of your body systems can be involved. So who should you do genetic testing in? Firstly, all patients with DEEs, and let me plead to the adult neurologists, your work is not done if you are seeing a patient with intellectual disability and drug-resistant epilepsy and you haven't thought about trying to do genetic testing, because as you've heard from Helen, you can just stop that carbamazepine in an undiagnosed Dravet patient and they can get brighter, they can become continent, you change their risk of status epilepticus with triggers. So it's really important. Who else? I think all patients with drug-resistant epilepsy deserve genetic testing. I would consider it in the idiopathic generalised epilepsies. And it's less, a child with select self-limited epilepsy with centrotemporal spikes, you're very unlikely to find something unless they roll into a developmental and epileptic encephalopathy with spike wave activation in sleep, a bit like Helen showed us. But there are self-limited epilepsies where it's really important because they're dominantly inherited, such as self-limited infantile epilepsy and self-limited neonatal epilepsy. So how do you go about it? And that's really, I think, why most people are here today. There are a host of different approaches we can try. Copy number variant studies, panels, exomes, genomes, trio approaches, and we need to think about what we don't know about and what we're not finding today that we might find next year. So a molecular karyotype, a microarray, is now the sort of cheapest first test you'd start with, and that looks at a copy number analysis of the whole genome, and we're looking to see if you have a microduplication or a microdeletion. And here you see a microdeletion on a copy number study, and here a microduplication. And just to say, sorry, that there are a whole range of copy number variants you can have. Apart from the obvious deletion and duplication, you can have inversions, insertions, and translocations. And some of these copy number variants are in the normal population. So you really need to be sure that they are the cause of a child's epilepsy. And the first thing you do is look to see if they're inherited. And then you need to look at the literature. Could they be a susceptibility allele, or are they the whole cause of that child's problem? And often it involves what's inside that deletion or duplication. There might be a bit of a gene, like the central part of a gene, it might be a whole gene, or it might be 200 genes. And remember, we all have copy number variants, every single one of us in this room, and yet we don't have these diseases. So it really needs a sophisticated understanding of it, of the findings. So do we have any need today to do a classical old-fashioned karyotype that we learned in medical school? And the answer is yes, there still is a place, and particularly for a syndrome like ring 20. And the reason for that is that that will not be identified in a copy number study, microarray. And you can see here the ring 20, and these patients almost always have drug-resistant generalized epilepsy with absence and tonic seizures, but they can be intellectually disabled and they can be of normal intellect, and it depends on the mosaicism load of their ring 20. So it's a disease that's rare, it's often missed, and this is a pointer, and at least you'll know then you can't go to surgery, and you have to think about them from in the point of view of drug trials, but they can be very, very severe epilepsies. So let's move on to gene panels, and I wanted to share a study led by our postdoc Karen Oliver, which I think is very important because it compared 4 diagnostic panels in Vitae, GeneDx, Fulgent and Blueprint genetics, as well as 2 research panels that were in common use. And Karen found that these panels differed in the number of genes on the panels from 144 to 511, but overall, over the 4 lots of diagnostic and research panels, in 2022 there are only 713 unique genes, which sounds a lot, but this is the problem. Only 111 genes were on all 4 panels. So if you don't look, you don't find, and that has happened so much with our patients that people haven't been looked at for the 900 genes we now know for DEEs and the 1,000 genes we know overall. I showed this the other day. This is the publicly available list of genes which we are updating. Karen and Bronwyn Grinton are updating this every 6 months so that you have evidence of robust monogenic genes, not just one report, but confirmed reports. And this has now already jumped up in terms of the number of genes and will continue to do so. But this is the most important. If it's negative, you need to keep looking at that data set because new genes are described every week, and it may be that your patient has a gene that wasn't known when you did that study, but now it is known and that you can find the mutation. But this is really where we need to move forward to exomes, because exomes mean you have a whole data set that you can come back to and re-interrogate. And in fact, what we're trying to do is more trios. So an exome is sequencing our exons, which encode 1 to 2% of our genome, and they are responsible for encoding your proteins. And we know today that most pathogenic variants are in the exome, but this field is changing all the time. So why perform a trio rather than a singleton exome? And that's because it's much easier to identify pathogenic variants. You get half your genes from your mum and half your genes from your dad. So if you have variant in your gene and mum or dad have it, it's unlikely to be causing the disease in front of you. It could be if it isn't fully penetrant, but if it's a severe disease, it's unlikely that the mother or the father are walking around with it. So you need to understand when you get a variant in a gene, does it cause a dominant disease or a recessive disease? And if it causes a recessive disease, particularly if you're looking at a consanguineous couple or an inbred population, then you need to go looking for the other allele. And that means you might have a clear pathogenic variant in one copy of the gene, but what about the other copy? And the biggest trap there is where you have, say, a deletion in the other copy of that gene, and that might be missed by exome sequencing, because if the whole thing's deleted, there's nothing to sequence. So then you have to go back to the copy number variant laboratory and say, I'm really worried about a gene, WWOX or something, and they look at that gene and they might find a tiny deletion, which has been the case in one of our studies of WWOX. So if you don't look, you won't find. And if the gene feels like it could be the right gene, then it's worth pushing very hard to get through that. So that means we need to understand the inheritance pattern, whether it's dominant, recessive, or indeed could be both. And then as new genes are discovered, you need to reinterrogate that data. And admittedly, we don't have the skills, I don't have the skills to do that, but I go back to our molecular geneticists, our bioinformaticians, and say, please have a look. And sometimes they need a bit of prodding, I find. So, you know, that's our job to try and tell them it still matters. So the field is now, panels are really gone. I think we're into exome sequencing where you can look at the data again, but now we're moving to genome sequencing, and it's very much in the research domain. Is it in the clinical domain? I think it is becoming in the clinical domain. It costs a lot, and so that's a problem. It's a problem for me to get that even in Australia, but it's certainly where we have to head. And those of you who heard my lecture the other day about these new genes, the RNU genes, they've been completely missed because they're in the introns. So it is very important to think more broadly. I think we've been a bit naive thinking that the non-coding sequence was rubbish DNA. I don't think there's much rubbish DNA in our bodies that has a purpose, and I think we're just beginning to find the secrets hidden there. So in genome sequencing, we all have 6 billion nucleotide sequence in our genome, and within that we have 5 million single nucleotide variants where we differ from the regular population. And here you see these are the different types of abnormalities that can be found. Single nucleotide variants with our 5 million points of difference, insertion deletions in a genome, 600,000 points of difference in each of us, and 25,000 structural variants. So it's very much like looking for a needle in a haystack, and that's why it's tough, but you do need to start to think about this. We can't do it, it's what our genetics colleagues do. So again, moving to a trio is more useful than a singleton because it helps you to sort out what's in your normal parents and what's different in your patient. So this involves huge data sets. And if you have a trio, you can immediately exclude an awful lot of those variants because half are from mother and half are from father. But then the next step is you've got a variant, it might not be in the parents or it's in an affected parent, so you know where you're looking and you expect, you know that parent should share the variant. But how do you tell if that variant is pathogenic? And that takes a fair bit of skill and know-how. The first thing is it present in population databases? And the best one that we use, but there are numbers that people put together, is NOMAD, and that's updated every few years. Initially, it had just 20,000 genomes in it. Now I think it has 100,000 genomes from healthy controls. And you can see that if that variant is in the regular population, the healthy population, it's not going to be cause of your patient's disability. Now you have to say, how do I know that population was healthy? And I think that in itself is a good question. So, you know, you might have a normal adult who's contributed to NOMAD, but they might have had febrile seizures. So if febrile seizures, you know, if your patient has febrile seizures and that the population has some people who have the same variant, it may be that it's still relevant. On the other hand, if your patient has a DEE and someone in the normal population has it, it's not the cause of your patient's disease. The next thing to do is it de novo? That's only useful if you're talking about a new gene change in that child. Remember, they can have an inherited change, such as in a Gef's Plus family, and the parent may have it and be mildly affected. or they might be mosaic. We have a whole range of in silico tools which we can use to evaluate that variant. So you've heard of CAD score. A CAD score incorporates 4 different in silico tools together to really try and crystallize, is this change going to make a difference to how that protein functions? Is it a recurrent mutation? That's really helpful. If you've got a mutation, the phenotype looks like Dravet, or you've got a variant, not a mutation, the phenotype looks like Dravet syndrome, and you look up Dravet papers and somebody else has had exactly that change, that helps to seal the answer for you. And most importantly, is it a phenotypic match? And that can be hard at the start. When a new gene is discovered, people like Charlotte Dravet, great example, she reported six children with Dravet syndrome. Is it a phenotypic match? Well, we now know that the phenotypic spectrum of Dravet syndrome is much broader than we had thought. And you have to understand the breadth of the presentation to see if the patient in front of you could have it. So there are lots of different factors you put together to decide if a variant is pathogenic. And sometimes it's unclear. Like I saw a child with a phenotype that could have been Dravet syndrome. Their parents were not available. They'd been drug addicts and the child was in care. And I thought, she looks a bit like a Dravet. She had an SCM1A variant. It wasn't recurrent. I put them together and I wrote to my colleague. I said, I think this is Dravet. And then it was sealed a year later when someone published that same variant. But I do think we have to bring our expertise in phenotyping to the table. And then, of course, trio genome sequencing helps us when new mechanisms are identified to go back to your data set and find other patients. So that's why I'm very excited about the RNU story, because we have just solved 4 of our very severe patients because of this new type of mutation. The other job that's important for us as clinicians is to interpret the genetic result. You have to be really careful that you understand what you're looking at when you're talking to the family and the patient. If there's a VUS, I don't discuss it. It means a variant of uncertain significance. Now, if I don't understand it, how am I going to describe that to the patient? And I think you just create complete uncertainty. And, you know, I would say there are some changes. We all have changes in our genome, but none of them are we sure of the answer. And I only want to tell you about those that are definite, and we will get further evidence, such as it turning up in another patient or with the same phenotype. And we should think about this every 1 or 2 years and keep looking. But I just had a very interesting example of this last week. I saw a child in 2019 with ALG2, 2 variants, 1 definite, 1 uncertain. But the phenotype was of congenital disorder of glycosylation consistent with ALG2. And I looked at what my colleague had said, another child neurologist who was ongoing with the patient, and she had said, oh, we're not sure. I had written to the world gurus of this particular disease, Hudson Freeze and Bobby NG, I don't know how to say NG well, and said, I think this child probably has it. Can you give me some information about this variant? So they've done more extensive testing. It's definitely abnormal. I came back to the parents last week. I went and looked at my letter in 2019 and I said, I think this will be the cause. And interestingly, the mother and the other clinician involved, the other child neurologist, had said they don't know the cause. But I was going on the phenotypic match. It just felt like they all worked together correctly, and it's right. But it's just interesting that people had not read my letter, I felt, and where I had said that I had thought it would be the answer. So you just got to remember, I guess, I took that away as I hadn't communicated my thoughts well enough because the parent had dismissed what I'd said a bit. But anyway, I think it just shows the importance of continuing to look and to firm up your diagnosis. Explaining results takes skill and time. You have to sit down with the parents, you have to be clear and concise, And I don't think you need to talk about variants of uncertain significance. I know I just said that, but I think it's a really important point. You confuse the families. We need to ensure they understand what we're telling them, or they don't, or that we don't find an answer and why that's okay. And if you're not sure or you're worried about how to convey this, ask your friendly geneticist and follow up and see them again and say, why, what did you understand, where are we at? So what about the ones we haven't solved? Well, there are a whole range of variants, and this is particularly in the DEEs because we've solved 50%, that are hidden. Structural variants, intronic variants, mosaicism is extremely important, alternate transcripts, repeat expansion, and epigenetics. And what about the future? Well, there are lots of exciting technologies that are being used, just begun to be used in the research domain, particularly long read sequencing, single cell sequencing, and of course big data with AI. And we're going to use a multi-omics approach where we can combine transcriptomes, proteomes, epigenomes, and look at cell-specific temporal and network regulation. So this is really to the future in the research domain, but I think very important.
So the first presentation is finished, and building on the genetic insight, and I hope the audience appreciated for the talk. And if you have any question, please type them in Q&A box, and we will answer at the end of this webinar. So our next speaker will turn to the electrical signature of the brain. The second lecture will be delivered by Professor Shang-Yeong Kwan. Professor Kwan is a consultant at the Children's Hospital of China Medical University and also visiting staff at the section of epilepsy at Taipei Veterans General Hospital. He is a past president of both the Taiwan Epilepsy Society and the Children's Epilepsy Association of Taiwan. Professor Kwan, he continued to teach EEG and epilepsy across Asia, even he retired in recent year. So let us now watch Professor Kwan on getting the best out of diagnostic EEG.
I will try to find out the secret of the reading this EEG. So how to get the best out of diagnostic EEG? Of course, you must have a very good EEG technician. That is the first thing. So I don't mention about it. To me, I think the most important are two things. The first one is understand the EEG basic. What is the polarity? If you do not know what is polarity, if you do not know what is field, what is voltage, what is how the EEG is spreading, then you cannot read an EEG. And the second thing is the most important is know how to use different montages. Do you know what is montage? If you do not have any idea of montages, then you will never successfully read the EEG. So the other thing is when you know what is montage, then you will know what is contamination. So you will never be treated by the EEG. Actually, all the EEG imagings has pitfalls inside, lots of pitfalls inside, okay? So we must avoid this pitfall. Now, if you want to avoid this pitfall, you must know what is an EEG and what is contamination, okay? This is the most important idea. So I would suggest you to read the American Clinical Neurophysiology Society guidelines. There are total 7 guidelines, including adults, kids, brain death, everything, and pre-surgical evaluation, monitoring. So I suggest you prepare this, all these guidelines in your computer. So the first part is very simple. Let's review the generation of EEG. And EEG is the recording of the electrical activity from the cortex, right? Then we put an electrode over the scalp, and then we recorded the activity. And these activities are mainly from the dendrites of the pyramidal cell. And where is the pointer? Oh, here? Okay, yes. I can see the pointer now. Okay. And the EEG signals we just mentioned, all from the cerebral cortex. And the currents in the extracellular space generated by the summation of EPSP and IPSP. Yeah. Okay, I don't need to mention again. Okay, this one slide is important. Actually, all the EEG activities has dipole. One side is positive and one side is negative. But especially, for example, the epileptic functory charges. Epileptic functory charges, spikes or shock waves, always shows a negative negative polarity upwards, perpendicular to the surface of the brain. If it located very close to the cerebral cortex, you put the electrode here, then you can well see the negative discharges with high voltage. But if the dipole, if the region is far away from the electrode, then the activity, the voltage will be faded. If the dipole is parallel to the electrode, then maybe you will miss everything, or you will get a very strange recording. Okay, and at times when you put the electrode just over the circus, then because the dipole has two directions, then the results will confuse you. So this type is the best recording. Okay, if the dipole perpendicular to the cerebral surface. And then we must know some other basic, what is polarity, phase, and voltage. This is very basic. In neurophysiology, all the waves downwards, we name it positive. And if the wave upward, we say negative. So if the two waves are in the same direction, for example, like this one, this is a slow wave. No matter this is a slow wave or short wave or spiky, anything. However, the direction is towards the same direction. Then we call it in phase. You see, this is a negative slow wave. This is a negative slow wave upwards. So in phase. And this is a positive slow wave. Positive slow wave, all points to the downwards. Then we say in phase. But here is a negative phase, and here is a positive slow wave. There is a positive phase reversing here, so we call it out of phase, okay? And here's a negative phase slow wave, and here, this is a positive phase slow phase and slow wave, and here is a negative slow wave. They point head to head, so we call it out of phase. So be careful of these two very important basic knowledge. In reference montage, we're all looking at the in-phase activities. In bipolar montages, we're all looking at the out-phase activities. This is very, very important basic knowledge. For example, like this one. On the left side is the reference montage. Can you see clearly the reference? In Taiwan, we usually use, this is also the Montreal method. The left parasagittal, right parasagittal, left temporal, and right temporal. This is, to me, the best montage in the world. No any montage is better than this one. Okay, left parasagittal region, right parasagittal region, from frontal polar, mid-frontal, central, parietal, occipital. The right, and the left, anterior temporal, mid-temporal, posterior temporal, and then cover the right lateral surface. Okay, left, right, left, right, left, right. 5, 5, 3, 3. Okay. So this is a reference montage. Let's see. We can see there is a spike here, followed by afterglow slow wave. Is it all in the same direction? That is in phase. And also the slow phase. Is it in phase? So this is a very, very beautiful, very, very beautiful recording. We can see here. I draw the picture here. Okay. The other side, we can see this is bipolar montage. In bipolar montage, we should looking for the outer phase. For example, like this one. There is a negative phase reversing. Actually, these two pages are the same EEG at the same time. I use different montages. So you can see different types of spikes looks somewhat downwards, upwards, looks somewhat changed. Okay, and even the morphology is somewhat different. But still we can find there is a negative phase reversing. Is it? This is downwards, downwards, and here is upwards, upwards the spike. So there is a phase reversing here, and spikes, if we say this is a negative phase reversing, okay, where is it? It is at T3, just like this picture. So in bipolar montage, we are looking at the outer phase, okay? Outer phase. Is that clear? Okay. Now, we're going to have some simple practice. This is an amplifier, okay? Amplifier can be found in all the electric devices, including your mobile phone and also in this notebook, everywhere, okay? This is the amplifier, okay? Amplifier in EEG, we have input 1 and input 2. Input 1 is A, okay? Input 1, also called G1, and input 2 is G2, and then G1 minus G2 becomes the waves we get, okay? For example, if input 1 is 0 microvolt and the input 2 is minus 10 microvolt, so 0 minus minus 10 equals to positive 10. Then you got a positive wave like this one. Okay, this is very simple to everyone, but becomes more and more complicated. Okay, input 1 0, input 2 positive 10, then 0 minus positive 10 get minus 10 becomes positive, becomes negative. 0 minus minus 10 get positive 10 downwards. Positive 10 minus 0, positive 10, the results, okay? Still positive 10 downwards. This is the real world, okay? This comes to the real world. So, A, B, C, D, E, F here. Here is the reference montage, is it? Okay, the same direction in phase. We can see the highest amplitude is located at C. If we put into, we transform this EEG into bipolar montage, okay? Since here, before this region, sorry. And what was that? How can I disappear? Okay. Here I reference montage. And from here, we transform into bipolar montage, you see? A to B, B to C, C connected to D, D connected to E in a non-breaking line, okay? So A to B, 0 minus 10, get positive 10, okay? Downwards. And then B is minus 10, C is minus 20. Minus 10 minus minus 20, get positive 10, downwards. And she's minus 20, D is minus 10. Minus 20 minus minus 10, get minus 10. Still minus 10 upwards, okay? And D is minus 10, minus 0, then we get minus 10 is our. So there is negative, is it? This is negative phase reversing, or we say the spike negative reversing, maximally C. And we can see this bipolar montage, there is C is the intersection. So we say the C is the maximal amplitude. Look, here is the reference montage. Here, and then, okay, the color did not show. On this side, we're like, oh yeah, very good color. Okay, here is bipolar montage. Okay, so you can see the spike both in reference montage and both in bipolar montage. But please remember, reference montage has several reference montage, and bipolar montage, at least you will have 2 bipolar montage. Later, I'm going to explain to you. Well, so for example, the second example, if in reference montage, this is a positive spike. Okay, this is a positive spike. Okay, if you change to bipolar montage, A connect to B, B connect to C, C to D, D connect to E in a non-breaking line, okay? A is 0, 0 minus positive 10, B is positive 10. 0 minus positive 10 get minus 10. You get a negative spike. And positive 10 minus positive 20, she's positive 20 now, so you got a negative 10 upwards. And she's positive 20, D is positive 10. Positive 20 minus positive 10, you got a positive 10, you got the downwards. And positive 10 minus 0, E is 0, you still got positive 10 like this one. So this time we got a positive phase reversing, is it? This is positive phase reversing, maximally at the intersection C. So this is the real world. This is reference montage. This is bipolar montage. Okay, is it simple? No, it is not simple. But since today you will feel to read the EEG is very, very simple if you have this idea. All the EEG which always treat you because of you do not know how to switch the montages between different referential montage to bipolar montage. Okay, I'll show you again. Localization, if this is spikes followed by afterglow slope. This is bipolar montage, you see? The left parasagittal, right parasagittal, left temporal, right temporal. We can see a negative spike with the maximum amplitude at T3, you see? And followed by afterglow slope. Okay, let's analyze this wave, this spike, you see? Just like this cartoon too. So maximum amplitude should be located at T3. And then we look at the slow wave here, okay, the slow wave. The slow wave looks somewhat different. Here is negative phase reversing, but the slow wave is positive phase reversing at T3. No matter what positive or negative, every wave is up and down just like the sea. Who is positive, who is negative? It's nothing, it's really nothing matter, you know. That's from your view, okay? To me, the lesion is here at T3. That's the most important. I can read this lesion from the afterglow slow wave. Of course, I can read this lesion. I can look at this lesion from the spike, right? So if you get it, then you can read EEG much better since today. So then let's come into the most important part about the montages and their pitfalls. What is a montage? Montage is a logically orderly arrangement of all the channels, so as you can read, you can see the anomaly very easily. So on the left side, you see this is not orderly arranged, the EEG channels. And then we put them into parasagittal, temporal, 5533. And then you can see very clearly, okay, the spice is here, is it? So this is montage. Montage is to help you to more clearly and more easily find the lesion, okay? So do not be afraid of a montage. Okay, here comes the montages. There are two types of montage. I will suggest you to read the EEG. In every EEG, you should use at least these 5 montages. Do not use only one montage. Always read the EEG with 5 montages, unless you are very, very senior as me, about 70 years old, okay? Okay, so reference montage, we say a common reference montage, okay? Because multiple, this is the definition, multiple scalp electrodes, the input 1 are connected to a common reference electrode, that is input 2. And what is bipolar montage? Bipolar montage is each electrode's voltage is linked and compared to an adjacent one to form a chain without breaking, okay? This is bipolar. This is the basic definition. So in referential montage, there are 3 types you must use in daily interpretation. The first one is ear reference. Never forget it. To put the reference at the ear loop, A1, A2, okay? The odd number is on the left side, even number is on the right side. That's international rule. And use CZ as a common reference electrode. And use common average, okay? And bipolar montage has 2 types. One is AP bipolar, anterior posterior bipolar. And do not forget, always use transverse bipolar montage. If you come to my video session yesterday, the first case, we find the spikes at the midline. Only can be seen in the transverse bipolar montage and not in other montages. So this is international 1020 system, okay? Everyone knows this one. And 1010 system and 105 system mostly for study, for research. So let me stress again, explain more deeply, explain what is reference montage. Reference montage is the input 2 are the same. We use the same electrode as a reference for example, ear referential montage on the left side, all electrodes connected to A1. So A1 is a common reference electrode for the ear referential montage. On the right side, all connected to A2. Okay, the purpose is to compare what is the purpose of this ear reference montage. So the ear reference montage, if you want to use, that is you are going to look at the lesion at the parasagittal region, okay? Only one purpose, look at the lesion at the parasagittal, because it is far away from the reference. If the farther the distance between two electrodes, you will get the more higher amplitude, okay? More clear results, okay? And then let's come to the CZ reference montage. We put the CZ as the common reference here. So all the electrodes connected to CZ, like this one, left, right. So what is the purpose of CZ montage when you choose? The only purpose is to look at the lesion at temporal region, okay? So if this is a case of temporal spike, I would suggest you never use, never, better avoid this, sorry. If this is a temporal lobe focus, I would always suggest you use CZ reference montage, okay? But if this is a case of temporal lobe seizure, I will never suggest you use A1, A2 montage, okay? Because the temporal lesion is very close to the ear, okay? And well contaminated the ear reference. Okay, this is very important. Okay, CZ reference montage is to look at the temporal lesions. And what is a common average reference montage? That means all the input two are connected to average reference, average potential. What is the average potential? Average potential is very simple. Just add all the electrode potentials, then get their average. Just like your score when you're a student, is it? Your score after a contest, your score always compare with the average score of your class. Is that? So this is the spirit of common average montage. It's very, very simple. Your voltage compared to all the voltage together, summation together, the average. Okay, but at times there are some outliners. So I will cancel these outliners in the basic average calculation. For example, FP1, FP2 are always contaminated by the eye blinking. And also I will cancel the central CZ, such like CZ, PZ, because always during sleep, the vertical shockwave K complex always comes from that. These are outliners, is that? They are always has very high voltage. Then you will change the average potential, okay? So I will avoid these electrodes in calculation. So let's come into the bipolar montage. Again, bipolar montage, please remember the definition. Each electrode's voltage is linked and compared to the adjacent one from a chain of non-breaking chain, okay, it's important. For example, like this one, F1 to F3, F3 to C3, C3, P3, P3, O1. So F3 is the first channel input 1, and F3 is also the second channel input 1, okay. F3 is the first channel input 2, sorry, and also the second channel input 1. This is the basic spirit of bipolar montage. So bipolar montage, we have two types. One type is AP bipolar, like this one, anterior to posterior. And the second one is the horizontal. Anterior posterior bipolar montage looks like a banana, so everyone can use double banana montage. And the transverse montage is look like the character E, so we call it E montage or E bond, okay? What is the purpose of a bipolar montage? Okay, the bipolar montage, AP bipolar montage, is for you to compare the anterior and posterior, which one is the maximum. Okay, which one is the boss? Anterior part is the boss or occipital part is the boss? And horizontal bipolar montage, transverse bipolar montage, is to compare the left and right to let you to know the left side is the boss or the right side is the boss. So if you combine both of this anterior AP bipolar and transverse bipolar, you will get a real picture of the EEG. Okay, so the design of bipolar montage, you should go straight like this one, go straight, okay, and never interrupted, okay, cannot be interrupted, and should not be like zigzag like this one, okay. You should just like arrange them in a straight line with equal distance between both two electrodes. So in the guideline recently published by ACNS IFCN, they say 10-11, 10-20 system. Please remember, 10-20 system is enough, is very enough for the routine EEG, for ambulatory EEG, and for video EEG, okay? No need to do what is 10, 10, 10, 10, 5 system, okay? This is enough, yeah. But in suspicion, if you cannot localize where is the epileptogenic focus by 10-20 system, okay, maybe you can add more electrodes, such like F9, F10, can you see the F10 here? And T9, T10, and P9, P10. Then the electrode up to 27 electrode. It can help you to identify whether the epileptogenic focus are located in the inferior surface of the temporal lobe or the anterior and middle and posterior temporal lobe, okay? 10-10 system can be used only in the pre-surgical evaluation and source localization. So forget it. Please remember, 10-20 system, use 21 electrode. It's enough for almost all the daily practices, okay, including the video EEG monitoring. So I will show you, this is the additional inferior temporal electrodes, okay. We can see this is the ordinary bipolar montage, left parasagittal, right parasagittal, left temporal, right temporal. This is the central two lines. And then comes the inferior temporal additional electrode channels. FP1 to F9, F9, T9, T9, P9, P901. And then followed by the right side, okay? We can see the spice here. But actually, after the study, if you put this inferior electrode, you can get not much information. Yeah, you can see if the spice only occurred at the inferior temporal electrodes. In this added additional electrode, there are only less than 3% patients. Okay, so to me, no much use, okay? The 21 electrode is enough for me, okay? So then, let's look at the spreading of EEG signal. Everyone is confusing about this one. You must have heard what is volume conduction. Yeah, because the body is a volume, okay? Body has lots of, for example, in your hair, you have scar, you have scalp, you have soft tissue, you have CSF, you have you have meninges, you have brain. So it is a 3D volume. So actually the EEG, most of the EEG signal are spreading through this volume, through this tissue, okay? This is what we call volume conduction, volume conduction. And the other is the EEG signals are spreading from nerve fibers, nerve threads, and the network of the brain. That is what we call nerve conduction. Okay, volume conduction is just like in our daily life when you touch if there is a shaka here, if I touch this, oh, I will get the electric shock. It's very quick. So this is volume conduction. Okay, it is a volume conduction, not nerve conduction. Okay, so volume conduction means if we look at this photo, this is the neuron. it generates the current, EEG spice current. So this is the primary current. But this is the surrounding brain tissues, extracellular fluid. So the currents from here, spreading from here, this is what we call secondary volume, secondary current. And secondary current spreading by volume conduction, by spreading through the CSF, by through the brain, parenchyma, by through the meninges, by through the scar, the bone, by through the scalp, and then record it. So this is what we call volume conduction, okay? Always mix together. So after I explain this, you will never forget what is volume conduction. We always put AP1, AP2 here, right? And you can pick up the eye blinking artifact, like this one. You see? This in AP1 channel, AP2 channel. Here are very high voltage slow activities. These are eye blinking artifact, you see? Yeah, no problem, because cornea has a positive polarity, and then if the eyes are roving outwards, and AP1, AP2 will pick up the positive polarity, okay? And if the patient closes his eyes, the eyeball will move. Oh, however, so this is the eye blinking artifact. How come, please remember, is there any connection, any nerve between the eyeball and the electrode AP1? No. Is there any connection, any nerve connection from the cornea, the left eye to the AP2? Is there any connection? No? No. Why the EEG shows very high voltage potential here? This is volume conduction, right? Is it? Because the eyes moves, and then this potential will contaminate the skin, the scalp, the eyelid, and the fat tissue, subcutaneous fat tissue, or the scar, the bone, and the CSF maybe. So all these are volume. So AP1, AP2, these are volume conduction. Is it? Is it clear? Okay. I think it's clear. Okay. So let's take a look. Okay. This I show you the volume conduction. Okay. What is nerve conduction? Nerve conduction is also very easily understand. So these are the brain, some fasciculus, for example, superior frontal occipital fasciculus, inferior frontal occipital fasciculus, and inferior longitudinal fasciculus. And here are some U fibers, and here are the corpus callosum. All these are nerve tracts, right? And anterior commissure, all nerve tracts. If the EEG activity, seizure activity spread through this network, it is called nerve conduction. Nerve conduction. For example, like this one, of course, mixed together, okay? This is a periodic discharge over the left side, and then there is a seizure coming from the posterior head region. We can see very fast activity, seizure activity spread widely, involve the whole left hemisphere and also the right hemisphere. It spread mainly through the nerve tract, through the network. This is a nerve conduction. Of course, please remember, always mix with volume conduction. Frequently, you cannot differentiate very well, okay? But please keep these two basic idea. So EEG spread usually through the volume conduction. So like this one, okay, if you throw a stone in the lake, then you will cause ripples. At the center, you will have the highest voltage, and at the peripheral, the ripple will have the low amplitude. So if these are the electrodes, if the distance between the two electrodes are far, then you will get the higher voltage. If the distance between two electrodes are shorter, then you get lower voltage. Okay, so this picture showing you is the field, is the concept of field, and EEG always has field. If the EEG shows no field, the activity shows no field, then it may not be an EEG. highly possibly it is artifact origin. So the field is very important concept in reading EEG, okay? So the most difficult thing for everyone in reading EEG is you wrongly choose the montage. How many minutes do I still have? 5 minutes only?
Yes.
Wow, you should give me 2 hours. Okay. Okay. Next time we should improve. Okay. Today is didactic. Okay, wrongly choose the montage, which makes you to read the EEG very difficult. And then everyone is confused by the contamination and the distortion of the morphology of the EEG, especially in bipolar montage. You see, bipolar montage, this one cancel that one, you will make distortion of the morphology and change the amplitude, and even the polarity will change, the phase will change, right? In bipolar montage. And this, the third one is too much artifact, okay? That's the technical problem. Which one is the elephant? This one, from the side, from the back, from the upper, the back, or from the body? Which one is the real elephant? No one is the real elephant. But if you combine all the images together, then you will get a real elephant, the image of a real elephant. So this is year reference montage, it is a CD reference montage, this is common average montage, this is AB bipolar montage and transverse bipolar. So you combine all the montages together, then you get a real EEG, okay? So let me tell you the pitfall in reference montage. If the two ideas, the electrodes, if do not reference electrode, if do not have any polarity, do not have any electricity, then we call it inactive reference. That is the best. Okay, the polarity is the voltage is 0. Okay, but if the reference has some potential inside, then we call it inactive. We call it active. Sorry, active reference. Okay, if a lesion, if there is a lesion over F4, for example, the spice over F4, then it will has a, what's that? Field spreading, is it? Volume conduction, field spreading. If spread to the CZ, if you use CZ reference montage, because F4 is very close to CZ, the field will very easily reach the CZ, will contaminate the CZ. Then CZ, originally it is 0 potential and now has some potential inside. So that's CZ becomes active reference. And if the second one, if there is a lesion at the temporal region, if you use A2 as the reference, from the volume conduction, T4 spreading, easily reach the A2 electrode. So the potential will be picked up by the A2 reference, just like I mentioned, the P1 and FP1, FP2 electrode pick up the eye blinking potential, the same, okay? Then the A2 becomes activated. So A2 becomes an active reference montage. Let's see. For example, this is a contamination of CZ, very, very important slide. On left side is reference, okay? No contamination, 0, -10, -20, 0, okay? If the lesion is at C3, C3 is the neighbor of CZ, is it? So very easily contaminated CZ. Then CZ becomes the same, becomes active reference, or carries almost the same potential as C3. C3 now is -20, and CZ becomes also -20. Then if we shift the montage into CZ montage, what will we see? Okay, 0 minus this, on the left side is A1, A2 reference montage, okay? And if we use CZ montage, 0 is -20, and -10, -20, because CZ is -20, please remember now, CZ is -20, and all here -20, what we get? We get this one. This is a false image. Okay, this is not good. This is a false image in CZ montage. So this is the most common pitfall in reading EEG. So let's finish with several EEG. So what are these activities, do you think? What are these one? This is CZ reference montage. What's that? It's the shock wave of high voltage located bisynchronously at the frontal polar region. Okay, you tell the neurosurgeon, that is epileptogenic focus. We should move. We should put SEEG over bilateral frontal polar regions and try to find out whether there is a lesion. Okay. Please remember, this is CZ montage. You haven't read other montage yet. Let's change it to bipolar montage. Wow, still looks weird. Where is the phase reversing? Is it? Oh, somewhat like P3, okay, and at P4, not more on maximally at the frontal polar region. But for the new beginner in reading EEG, they always say, oh yeah, still there's a maximal at the anterior head region, frontal central parietal, is it? Maximal here, okay? Okay, no, that's not correct. This is bipolar montage. There's distortion and change the polarity, change the phase. And let's come back to A1, A2. Then you see the real beautiful, what's that? K-compress or vertex shock wave, located maximally at the central parietal region. So this is the real EEG. So when you are reading EEG, you should not be treated by those contamination by pitfalls, okay? The final four. Can still have time? No ringing, no warning.
Because
okay,
they forget.
What's this? Forget. Look at this one. Everyone say, oh, this no doubt 3 Hz spine wave. No, to me, this EEG is too ugly. I will never show this EEG when I in my lecture. I will never use this one because this is bipolar. It shows change, it shows deformity, it shows change of the polarity, it has distortion. Okay, this is bipolar. Okay, 3 Hz spine wave. And then if we change to CZ, this is still 3 Hz spine wave, but looks very weird, is it? Very weird, very weird. So what is the best montage to show this 3 Hz spine wave or other spine wave, including slow spine wave and fast spine wave? You should always keep in your mind, only A1, A2, only year reference, only year. See, there's no combination. It shows the real picture, the most beautiful spine wave, spike followed by afternoon slow wave, without any contamination. Okay, so I think this I should conclude my lecture today. No enough time. See, use this one. 3 Hz spine wave in different montages. All looks different. Okay, and at last is in ACNS they say 16 channels is enough for daily practice. Okay, thank you everyone. Thank you for joining this didactic day.
So everyone, the second video is finished, and I hope the audience enjoy learning how to find focality from the EEG. And if you have any questions, please type them in Q&A box, and we will answer at the end of the webinar. And now I will hand over to my chairperson, Professor Ingrid Scheffer, to introduce the next speaker for the third lecture. Professor Scheffer, please.
Thank you so much, Kamornwan. It's lovely to see you. And indeed, lovely to see my very dear friend and colleague, Professor Helen Cross, who I hope everybody knows is the president of the International League Against Epilepsy. That's just one of her many claims to fame. The other is that she's the Prince of Wales Chair of Childhood Epilepsy and Director of UCL, Great Ormond Street Institute of Child Health, and of course, a paediatric neurology consultant at Great Ormond Street Hospital for Sick Children. And the list goes on. I'm not going to keep going, save to say that she's one of our leading lights in the world of epilepsy, and it's always a joy to hear her speak. And she's going to tell us or answer the question about why am I still having seizures?
Okay, thank you very much. And again, thank you very much for getting up so early to come to this session. So it's my pleasure to talk about, over the next 20-25 minutes, about when patients present to us continuing to have seizures, how should we think about this? How should we move forward, and what are our options? These are my disclosures. So if we think of the start of the overall prognosis of epilepsy, there have been many studies over the years, although I have to say we have a difficulty in looking at those studies in part. Surely from an epidemiological point of view, the methodology is sound, but of course we've changed our terminology and diagnosis over the past 20 years. But I found this study, which was the prolonged study that was led by the late Ettore Beghi, fantastic epidemiologist, and talking about long-term follow-up of patients in Italy, looking at just the precise diagnosis, treatment and outcome over a 10-year period. And you can see they recruited in excess of 1,000 children and adults. And you can see here 77% achieved a 5-year remission. And this is a consistent figure that we see over the years, regardless of the way we define the epilepsies. We have 3/4 achieving a degree of remission, 1/4 continuing to have seizures in the longer term. So why do seizures continue? That question that we ask ourselves in the clinic. Well, I think when we're re-evaluating each patient, we need to ask, is the diagnosis correct? Is it epilepsy? And even in an individual, of course, with long-standing epilepsy, with a new presentation of different events, are these still epileptic? Is there a syndrome diagnosis? Has the appropriate anti-seizure medication been utilized either for the seizure type or the syndrome? What is the likelihood in this individual of response considering the diagnosis that we have? And is there an alternative way forward? So in a re-evaluation, and I'm not going to stand here and go through the complete differential diagnosis, which perhaps in children would be different to adults, and we could have a whole session on differential diagnosis. The first issue is it an epileptic seizure? Are what the individual's presenting with continuing epileptic seizures? And as I said, even though they have a diagnosis of epilepsy, that doesn't mean to say that new events may be non-epileptic, may be another presentation that we need to consider. If we decide that they are epileptic seizures, what type? Can we formulate an epilepsy syndrome? Do they have an epilepsy syndrome? We may have already diagnosed that, but ultimately now we need to think, is there an underlying cause? Because that may have an impact on our overall management. And if we reflect back to the classification framework led by my esteemed colleague who's chairing the session, of course we need to look at it, and it does help us evaluate as we go forward. What is the seizure type? The epilepsy type? Can we possibly diagnose an epilepsy syndrome? And that's important in one aspect because we look at the comorbidities or multimorbidities. Are they really comorbidities? They're integral to the overall epilepsy, and ultimately the underlying cause. So then we move forward to, have we used the correct medication? Have we chosen the right medication with regard to the seizure type or epilepsy syndrome? And sitting there with an individual who may have deteriorated, had an increased seizure frequency, is there a possibility that the medication we have used has exacerbated the seizures? To give an example, I'd give an example of a 6-year-old girl with a history of episodes of being difficult to wake in the morning, that she'd had an erratic sleep pattern over the previous 6 months and become overactive and aggressive, and her speech had deteriorated. And then she had a further episode where she was difficult to wake in the morning and came for evaluation. This was her EEG, which indeed shows here central temporal spikes, The assumption was that this was possibly the presentation of self-limited epilepsy with central temporal spikes, and she was actually initiated on carbamazepine. But then she deteriorated further. She developed, her behavior deteriorated, she developed multiple jerky movements and episodes of eye flickering with some suggestion of impaired awareness. And this was her wake EEG. We didn't need to do a sleep EEG to determine there'd been activation of spike wave. And this was almost certainly the result of activation of this by the carbamazepine. With subsequent withdrawal of carbamazepine, there was improvement, and with a switch to a different medication, ongoing improvement. And then we come to the syndrome diagnosis, in the sense that a syndrome that we talk about a lot, not least my colleague who's chairing the session, and this is Dravet syndrome. So essentially, we know the usual classic history of this, and acknowledging that by the time they come to adulthood, it may be difficult to determine the early history of presentation in the first year of life with prolonged seizures, subsequent development in the second year of life of multiple seizure types, and then the developmental delay being progressively apparent. And yes, in adults that may be difficult to determine, but as we know that in excess of 90% are associated with pathogenic variants in the SCN1A gene, loss of function variants, in an individual presenting in adulthood with epilepsy since infancy, learning disability, and an associated SCN1A mutation, then it's likely that this individual has Dravet syndrome. And we know that it's a lifelong condition. Can we really impact on the overall outcome? Still unclear at the present time with our current treatments. But that said, with the careful definition of this syndrome, we've been able to determine the medications that are most likely to work, not least with the most recent of the algorithms that have been put out there with a degree of evidence base. First line, sodium valproate. Second line, the addition of stiripentol and clobazam. Ultimately, yes, in the first 2 years of life, we can use topiramate, ketogenic diet, but we have now evidence base from 2 years of age license for utilization of cannabidiol and or fenfluramine. But the other key issue in this particular algorithm is this point here, avoiding sodium channel blockers. And where we make the mistake in pediatrics often is the fact that they present with what appear to be prolonged focal seizures, even focal status epilepticus, and individuals make the mistake of saying, oh, this is a focal onset epilepsy, we'll start them on carbamazepine. And that can lead to a deterioration, and we know that actually this can affect the cognitive outcome in the longer term. So it's really important to make an early diagnosis and avoid sodium channel blockers. And of course, when we get to adulthood, have they been on long-term sodium channel blockers? Should we be looking at a re-evaluation? It is never too late. And I say this because this is a series of adults that were determined in a residential institution just outside London by my colleague Sanjay Sisodia. He went round the whole of the Chalfont residential institution testing, genetic testing, and found 22 with an SCN1A variant, and went back through the clinical history and determined that these were Dravet syndrome. And they looked at the occurrence of symptoms over life. They had neurological deterioration throughout life, but most specifically, 7 had drug changes following the diagnosis, 3 had meaningful follow-up, 2 had an improvement in cognition, 1 spontaneous language for the first time in his life. And I say this, he was 60 at the time of diagnosis. So it's never too late to make a change. So we have to think not only do we need to think about what medications are optimal in the seizure type or syndrome, but which anti-seizure medications to avoid. And here just some suggestions. It's usually the sodium channel blockers, particularly in some of the generalized seizure types. And of course, in some of the syndromes, we need to think about medications that may aggravate the issue. Lennox-Gastaut syndrome, we've got lamotrigine there. It may, we use that in treatment, but we must think about the fact that we must think about the fact that it may aggravate seizures. We have to think of it in our mind. If we have an individual in front of us that may have had an aggravation of seizures, could it be the medication? But as I've said right at the beginning, we continue to treat our patients, but we continue to have 25 to 30% who are still continuing to have seizures despite our medication. And despite the new medications that we see, the real escalation in numbers of medications that we have for the treatment of epilepsies, looking at the Glasgow studies, and this is the data on the right, despite they've done studies 30 years apart of new onset seizures, following them through and determining the actual failed rate is still exactly the same. Still 30% having continuing seizures despite medication, and if they fail second and third regimes, only 11.6 or 4.4% having seizure freedom. So are our patients really any better, the result of these medications? Or is it the fact that we've got an ease of use, less adverse effects moving forward? We can think about the advantages of the newer anti-seizure medications. Supposedly greater efficacy, although we've got no real evidence of that. That said, if we evaluate them, they've been evaluated in individuals who've tried all the other medications, and the benefits we've seen have been in those individuals in the trials. We've not really got evidence, although it's put forward, of the ability to prevent or delay the onset of epilepsy. But maybe fewer adverse effects than the available drugs, ease of use, linear pharmacokinetics, longer half-lives. The disadvantages often is the availability, possibly the expense, especially when the newer drugs come out first before they become generic. Longer-term review of their success and retention rates initially may not be available, and the long-term safety is often in question because we don't have that data. Much of the evidence base we have, of course, for the use of the anti-seizure medications are from randomized controlled trials, and they will tell us about short-term efficacy relative to a comparator, although normally, in the first instance, of course, that comparator is placebo. It is not a direct comparison with the best other medication. It will tell us about common adverse events and pharmacokinetic data. But what the randomized controlled trials do not tell us are the optimal dose we might use, the benefits relative to other existing medications, long-term retention or benefit relative comorbidities, seizure aggravation that I've already talked about, and any synergistic action that we can tell with other medications. But that said, what our randomized controlled trials do, and then on longer-term open label, is give us an evidence base from which we might be able to determine algorithms for specific types of epilepsy. And this, the most recent one that we've put forward, and it seems that my reference has disappeared into the white, but essentially this is the most recent algorithm we published in Epilepsy Europa in December with regard to the treatment of Lennox-Gastaut syndrome. And again, starting with a broad spectrum agent, for example, sodium valproate, and then working our way through those for which we have the most evidence base, but also looking at other things, other alternatives in parallel, which I'll come to in a minute. But it's never too late. Again, I say this. And although there is the issue that after the evidence base that after a trial of a second medication, the likelihood of achieving seizure freedom with a third or a fourth medication is relatively small, in the region of about 10%, there will always be those that respond. And whenever I see a patient in front of me to decide, where do we go next, there is always an option, even if they've tried many different medications. Do we stay where we are? Do we look at a new medication? Do we revisit a medication that we've trialed in the past? But the other thing is, when we have an individual in front of us, yes, we have to ask the likelihood of gaining seizure control. What is realistic when we consider the epilepsy syndrome, the epilepsy type? But also, when evaluating whether a medication has real of benefit, we need to think about over what period of time we are evaluating and comparing now with at what time point in the past. And these are actually a series of seizure charts from a young people's residential institution in the south of England. And one of my colleagues took out 64 of these seizure charts and put them in front of two of us and asked us where we thought medication had been changed. And we got it correct in 2 out of 64 cases. And essentially, the top left, you can see that seizure frequency is going up and down per month, regardless of what we do. We could say on the right, top right there, where my pointer is, if the medication was changed here, there is a sustained improvement over a period of time. But here, you could think, well, if I assess it here and change my medication and then assess it here, I think there was a huge success. But actually, it's got a very cyclical point to the seizure frequency, and therefore we've got to wait a considerably further point of time in order to assess whether there's been benefit. And the same here, you can see the cyclical point, but you could think that maybe we've changed medication here, but actually we haven't. So looking at our medications, we've really evaluated this. We haven't exacerbated seizures with our medication. We're using the right medication that we think would benefit them. Are there any alternatives? And maybe in most instances, thinking about these in parallel rather than necessarily instead of medication. Of course, we have the ketogenic diet, a high-fat diet designed to mimic the metabolic effects of starvation, used in the treatment of epilepsy for now over 100 years. And we have a randomized controlled trial here, which is one we performed in 2008 in children, which demonstrated benefit at 3 months over and above no change in treatment. And there have been further studies since then, one in the modified ketogenic diet from here in India. There was an adult study attempted, but the difficulties in recruitment reflected the difficulties really in utilizing the ketogenic diet in adults. But now, whereas 10 years ago we had, well, in fact, 15 years ago we had no randomized control trials in the Cochrane Review, we now have 13 randomized control trials in 17 publications. And essentially, although some of these randomized control trials look at ways of implementation, overall, it demonstrates benefit in the ketogenic diet over and above care as usual or no change in treatment, in the treatment predominantly of children, although the suggestion is there with regard to adults. And of course, there may be, and this is the first point I'm going to make regarding the underlying cause, because the underlying cause may direct you to this as a first-line treatment, not least for glucose transporter defects, where treatment with the ketogenic diet provides an alternative fuel for the brain over and above glucose, and therefore is the treatment of choice. We need to think about surgery. Is surgery an option in the individual in front of us? This is a set of guidance that was produced by the task force from the International League Against Epilepsy, where they utilized a Delphi consensus from all over the world in order to determine referral guidelines with regard to assessment for epilepsy surgery, because of course we need to refer to the centre where they have experience with regard to this. And they clearly state that there should be referral for a surgical evaluation offered to every patient with epilepsy as soon as drug resistance is ascertained. A surgical referral should be considered for older patients who have no surgical contraindication. A surgical referral should be considered for patients who are seizure-free on 1 to 2 anti-seizure medications, but have a brain lesion in non-eloquent cortex for which it would be low risk to remove. And this is important because, of course, surgery will give the only way of cure, namely seizure freedom and weaning off medication. The only contraindication to referral for surgery, apart from the fact if you think there's no focal onset seizures, is to patients with active substance abuse who are non-cooperative with management. And then if surgery isn't an option, maybe neuromodulation. First of all, vagal nerve stimulation. We've had this for a very long time. Suggested that around 50% of those who have vagal nerve stimulation get about a 50% reduction in seizures. And the other advantage with this is not only do we see improved benefit over time, but also we have the possibility of stimulating with the magnet should they go into a seizure, maybe to abort a seizure or indeed state prolonged seizures. And increasingly now, talk about deep brain stimulation. Still in the evaluation phase, I would say. We have the Estelle trial, which I know there's going to be a talk on later today, which looked at adults with Lennox-Gastaut syndrome and stimulation of the centromedian nucleus of the thalamus, demonstrating benefit, particularly electrographic seizures, but in the longer term, overt seizures. And we are beginning to evaluate this more in children. And looking at it, we're about to conduct a trial in Lennox-Gastaut syndrome in children at our institution. But still not routine, something that's still undergoing evaluation. And then we also need to think a bit about why the epilepsy is refractory. Yes, have we utilised the right medication, but is the epilepsy in any individual got an inherent treatability? And this is where the 30% continuing seizures is, in 30% of our population continuing to have seizures is really relevant. And there has been a lot of talk about the fact that is it related to the way the medications are taken up into the blood-brain barrier. And maybe variants in specific genes, not least the ABCB1 gene, which codes for P-glycoprotein that transports the drugs across the blood-brain barrier. Certainly this protein has been seen as an overexpression in tissue that's been removed for surgical treatment of epilepsy. Numerous polymorphisms have been described, but any implications for ongoing treatment of our patients is yet to be determined. So finally, in the last few minutes, I just want us to think a little bit that we're beginning to think about, particularly the early onset epilepsies, developmental and epileptic encephalopathies. Are we really treating these in the right way? And should we be really thinking about the cause more than actually necessarily ongoing symptomatic treatment, which is of course what we've been traditionally undertaking? And we need to think of these more in the fact that these aren't the ongoing issue isn't just the seizures, of course, it's the range of other multimorbidities that are seen in association, which actually are integral to the whole disorder. They're not comorbidities as such. Certainly, if we look at where all the genetic abnormalities are and what they code for, we're getting more of an understanding of the underlying pathophysiology of these conditions. And what is being proposed is more in the way of precision treatment, not least an increasing number of variants for which we may see alternative treatments that may be repurposed because they actually target the pathway for which that gene may be responsible. And maybe if we undertake early diagnosis and early treatment, could we have an impact on the ongoing other comorbidities that we see rather than just the seizure control? And certainly we're beginning to see more in the way of genetic therapies for some of the disorders, not least Dravet syndrome, being evaluated. Perhaps a key, just to give a couple of examples, one particular example of looking at the pathway, of course, is tuberous sclerosis. We know this is due to variants in the TSC1 and or TSC2 genes on chromosomes 9 and 16. And if there is something wrong with the complex, then that leaves the mTOR pathway unchecked, leading to the various manifestations that we see. And utilizing mTOR inhibitors has been determined both in open label and randomized controlled trials to have an impact on the epilepsy, not just the growth that was seen in the kidney or the giant cell astrocytomas. But more importantly, I think, is this, namely that there are various gain-of-function sodium channel mutations that respond promptly to sodium channel blockers. So this is the reverse of what we see with Dravet syndrome, but in gain-of-function mutations of SCN8A, SCN2A, in epilepsies presenting in the first year of life, sodium channel blockers such as carbamazepine and phenytoin can cease the seizures. These are medications that we've not traditionally used in the first year of life, but certainly we're now increasingly using them. And also in KCNQ2 encephalopathy, not the self-limited neonatal seizures we see, but that ongoing developmental and epileptic encephalopathy that's seen in some of those children that also respond very promptly to sodium channel blockers, probably because the sodium channels are co-located with the potassium channels on the membrane. And just to finish, that it's not all about the etiology though. And some of us are getting very focused on etiology. Don't forget our syndromology. This boy came to us at the age of 11 years for evaluation. He had his first seizure at 10 months, what appeared to be focal onset seizures, then increased in frequency, evolved into other seizure types, including recurrent jerks and more prolonged stiffening episodes from sleep. He was determined to have an SCN2A mutation, put on sodium channel blockers, a suboptimal response. Continuing seizures, what else could we do despite the use of multitudes of different anti-seizure medications? His EEG, if I tell you he was having drop attacks and prolonged stiffening episodes from sleep. His EEG showed slow spike and wave and paroxysmal fast in sleep. This was an electroclinical diagnosis of Lennox-Gastaut syndrome. Yes, we had an underlying etiology, but with a syndrome diagnosis, it opened the doors to us utilising other medications, not least rufinamide, cannabidiol, and now we'd be able to use fenfluramine. So in summary, continuing seizures should herald a complete re-evaluation on a regular basis of the individual. Is it epilepsy? Have we got the syndrome diagnosis right? Is there an etiology? And then we continue to have to ask those questions. Have we used the right drug? What is the likelihood of response? What are we treating? How do we define a response? Is there an alternative way forward? But ultimately, we should be continually discussing with the family and the individual which way they want to go at this point, what is the most important thing to them, continuing to evaluate their management and individualizing their treatment. Thank you very much.
So all three presentations are now complete, and we are now open for the floor for the questions. And I can see one question from the chat box, and I would like to ask the opinions of three speakers. So Dr. Isaac, he asked about for the special condition with DEE with spike and wave activated in sleep, what is the treatment of choice in this condition, and what we should expect when we treat these kinds of patients, and also the role of CBD in this syndrome. So I will ask all three speakers.
I think you should go first, Helen, because it relates to your talk, but you've got your mute on.
Apologies, yeah, absolutely. To be honest, I think the first thing is to assess what the impact of this is. I think if it's a de novo spike wave antivection with cognitive and behavioural regression, then it's a relatively urgent treatment that needs to be considered, and that what we're trying to do is improve the spike wave activation. And there needs to be a significant difference. I mean, classically, it's been over 85%, but a significant difference between the wake and the sleep state. So you're looking at definitive continuous spike wave activation in sleep. The reason I say this is there are many developmental and epileptic encephalopathies where there's a lot of spike wave activity in sleep, but there hasn't been a clinical change in the individual. And therefore, it is difficult to know what you're targeting with the treatment. When we've decided that actually, yes, it needs aggressive treatment, if there's been an acute deterioration, certainly the medication that has been utilized of choice is steroid treatment, with key, whether it be oral prednisolone or dexamethasone or pulse steroids, depending on the local utilization. But and for a period of time, and the target would be, yes, looking for cognitive improvement, but also normalization of or dramatic improvement of the EEG. Then following that, then benzodiazepines, clobazam, for example, And ultimately, we have utilised lamotrigine and ethosuximide. But I say again that what we're wanting is clear targets with regard to treatment, particularly with behavioural and cognitive, well, particularly cognitive improvement, if not language improvement, if it's a Landau-Kleffner type picture, and an improvement in the EEG. So we need to have start of treatment and then 6 to 8 weeks following a repeat EEG. And we're usually talking about 24-hour EEG to make sure there's a significant period of sleep.
Thank you. And Ingrid, anything to add on these difficult patients?
I think Helen gave an excellent answer. I do not have anything to add.
Okay.
So, Dr. Kwan, do you have something to add?
No, actually, I am an adult neurologist, but as I know in Taiwan, all my pediatric colleagues, they will use a steroid in these WAS patients.
Actually, Dr. Isaac asked the question that I would like to ask you guys. My patient who has DEE with SWATs, they don't respond very well with steroid, and when I try other medication, they still have some electrical activity and difficult to treat in this condition.
I think that there does have to be evaluation of this. It's usually the ones that have had acute deterioration that respond to steroids. And there is often confusion when the sleep EEG is done and there is a lot of spike wave activity. Is that really significant, or is it a reflection of the underlying cause? So this is where I say there needs to be specific targets at what we're trying to treat. And indeed, in some of my patients, if I've utilized a benzodiazepine and they've become more drowsy, actually that's worsened the spike wave activation in sleep. So it becomes a balance in determining what the target of treatment is as you move forward. And as I said, ethosuximide can be useful, lamotrigine can be useful, and of course valproate.
Okay, thank you. So we move to the second questions. So for the condition as SCN8A, so you say that sodium channel blocker is the treatment of choice, is the most helpful. But in reality, some patients with SCN8A, they don't respond very well with sodium channel blocker. So what is behind the scene? Is that because of ABCB1 gene, the refractory gene?
Well, now I'll start. Perhaps Ingrid may want to comment on this. First of all, we need to be sure that the variant that they have is a gain of function variant and not a loss of function variant. Because of course, if it's a gain, sodium channel blockers will work if it's a gain or are likely to work. They don't work in everybody, but are likely to work in a gain of function, but they will not work, and they may aggravate, of course, if it's a loss of function variant. But then, no, I do have some patients where they haven't responded to even to higher dose sodium channel blockers, and it's a gain of function. So it may be another sodium channel blocker that, if they haven't responded to phenytoin or carbamazepine, maybe in some of them actually lacosamide has been helpful. But also then looking at the electroclinical syndrome to see whether that may point you in the right direction as well. Ingrid?
Yeah, thanks. I think it really depends on the epilepsy syndrome, as Helen was outlining. So, of course, with SCN8A, you can have the self-limited phenotype with the movement disorder, and you can have the DEE, and the DEE, the developmental epileptic encephalopathy, can be quite challenging. But there are many types of sodium channel blockers. Topiramate has an action on sodium channels, valproate. Many of the drugs do. So because one doesn't work doesn't mean another one will not work. So I consistently move through, and same with severe DSWAS. I constantly move through the drugs I give a 3-month trial when I constantly move. It's not a quick trial, it's build it up, give it a proper trial and take it away. But I think it does depend a lot on etiology with DSWAS. And also, I'm sort of going back to the last question, but it depends on your expectations. So with DSWAS, you won't clean up the EEG, but you may lower the amplitude of the spike wave activity. and that can be associated with clinical improvement. So I think it's important to know what you're aiming for. With the patients I've cared for with GRIN2A, which was the first gene we found for that, they don't necessarily respond, but they do get better with time. So etiology and syndromology, the same message that Helen's been giving.
Yeah, okay. Thank you for the answer. So I think our time is limited. So Ingrid.
Yes, well, I'd like to finish by thanking the wonderful speakers for the session, for coming online, thanking the ILAE, particularly Jenna and Andrea, for making this all happen. Most importantly, thanking the audience for giving us their time this morning, afternoon, and evening, depending where you are. Thank you all.
Thank you.
Thank you.